Welcome to Indian Medical Association weekly webcast, which is usually held on Thursday. And today, with us, Dr. Monga is here, is the Finance Secretary, and the expert, Dr. Manoj Sharma, who is a qualified radiation oncologist. He did his post-graduation in super specialization from BHU some 40 years ago. And he has been working in this field very devoted. And he has done training in oncology in one of the best hospitals in Chennai. And he is advisor to Government of Delhi on cancer control program. And we all very much understand the control of cancer needs what? The most important thing is the prevention of cancer, early detection of cancer, the treatment, and to follow up the treatment and make sure there is no gap in early diagnosis, prevention, and treatment. One has to take a decision at what time they should go and try to investigate for early detection of cancer and what are the ways available to early detect cancer. And nowadays, everything is so common and the investigations are so easily available, at least in bigger cities. I'll not say in all the remote areas, but if we understand the basic things in prevention and early diagnosis, then we will be doing a lot of good work for the community, which is really suffering because the increase in number of cancer because of various reasons. So I'll request Dr. Manoj Sharma to first take up the issue. What are the common causes nowadays which we are feeling is really increasing the number of cancer? Dr. Manoj.
In fact, before you say, for the benefit of general practitioners, a GP is a person whom every patient goes with every complaint from cough to headache to any pain anywhere. And diagnosing that it is a cancer, it can be cancer, it cannot be cancer. And then we talk about the preventions also. So a GP oriented working is today's domain. Now we are talking
It's all my lifetime work actually.
Sure.
Can I start?
Yeah.
Very rightly questioned, and that's the issue which we have been facing for quite some time. You see, to summarize the cause of cancer in our country, nowadays a very common word you must be hearing, and that's called lifestyle changes. To tell you the truth, the lifestyle in India and with our people, our women, our men, is such that they can be, in some situations can be easily modified, and in some situations there is a very strict regulation which is required to modify it. So if we come to the first cause, number one, of cancer in our country, it's tobacco. And tobacco, if you try to understand, you must have read at your undergraduate level that the tobacco is cause of at least cancers of 17 to 20 sites. And you can see their prevalence and you can see their dominance in various parts of country. If you go to North Karnataka, you will find that it is esophagus. Assam, it is esophagus, because if you go to Bihar and eastern UP, you will find kidney is the cause. If you go to some affluent sections of society, smoking is the cause. And then if you go to Andhra Pradesh, you will find there is a reverse smoking which is still prevalent there, that's called chutta smoking, and there is a cause that causes the cancer of palate. Actually, Indian Council of Medical Research statistics about 20 years back, they have showed a very high incidence of urinary bladder. Urinary bladder was at number 7 in the 10 common cancer list in Delhi, while other places like Bombay, Chennai and Bangalore, it was not there, because the migrating population in Delhi, the smoker population is so high, so urinary bladder cancer. Then we come to pancreatic cancer. In general, we say head and neck cancer. You talk tongue, you talk cheek, you talk larynx, or hypopharynx, nasopharynx, and so on and so forth. and also gynecological cancer, cervical cancer. We are talking about the breast cancer also has some evidence that the smoking helps. So tobacco is a major cause of cancer in our country, and believe me, some 50 years back, I can say 1957, the person whom we call as the father of oncological sciences, Dr. S. Krishnamurti, said that 80% of cancers can be removed in this country with a stroke of pen, and the stroke of pen has to come on tobacco. That doesn't seem to be happening. This is number one.
So, Dr. Sharma, one thing I'd like to understand, because you have enumerated almost each and every cancer which has got some relation with the smoking and tobacco.
Yeah.
So now, the one simple question will come in the mind of my general practitioner: how the breast cancer and the cervical cancer be related with smoking?
Very interesting. As a matter of fact, you can add in this list how the urinary bladder and the kidney cancer.
Right.
So once the smoke, I forgot to mention about the root of these causes. The root of these causes is inhalation, and that is where the lung cancer is caused. So when these when the smoke is inhaled and it has got all the carcinogenics available, I don't want to enlist them here. It passes via bloodstream, and that carcinogen has got effect on very sensitive areas like sternocolunar junction of cervix, or the lobules in the breast, or the filtration system of kidney, or the surface of the urinary bladder, that is epithelium of urinary bladder, urothelium, where it stagnates and stays for a very long time. You see, so that is the way it works out, and this statistics has come from developing countries where the women smoke quite a lot. So we have to look at that angle.
The trend is changing in India also. The women
Yes.
are smoking, but the most important thing is when you are fighting about that the cigarette packs and tobacco packs should have some 75 to 85% of information about the cancer, but 99, rather I'll say 100% cancers are related only with the mouth or the lung. We have not shown anything about these common cancers, because this thing I think general practitioners should understand, rather every one of us should understand, and then this message should go to general public. It is the hereditary factors which are leading to many cancers in breast and all those things, but smoking adds to that cancer. So
I
this
think general
information is-
practitioners, to tell you the truth, that general practitioner and your Indian Medical Association can form a hub to convince our policymakers, let us be very frank, and the governments, respective, whichever, to do something very serious about tobacco. Because almost 70 years, we have been harping, counseling, teaching, awareness, nothing works. Then they said de-addiction center. What is the statistic of de-addiction center? Guys, first of all, doesn't want to go there. You spend so much of time there, money there, and then he is back to the addiction. And moreover, how much is the infrastructure and money and trained psychologists, clinical psychologists and doctors required to do the addiction? So the first thing is to sort of taper off the usage of tobacco by various ways, by countries like, I remember one Canadian met me by installing a telecobalt machine. He said, for $1 cigarette packet, I pay $5 extra. And then you must have heard the famous statement of Hillary Clinton, who raised 400 to 500% taxes on tobacco products, and she said, by doing this, less of smoke will enter into our people, our children and their children. And as a matter of fact, that will save a lot of money on their insurance.
But then, is there any country in the world which has really, stopped the use of
Yes.
tobacco?
They see Argentina has stopped farming of tobacco. They are putting sugar cane for gasohol. And you must have heard about the story of Paris, where 40-50 people are dying every day. So they have banned it. And many countries, I think this debate came on internet. And I said, you search, and the guy searched and found many countries they have banned tobacco. See, the issue I tell you very important, which we fail to realize. Dr. Reddy, Dr. Rath, under ICMR AGs, they have done a research that 17 times more money is spent on healthcare related to the tobacco related cancers than the revenue earned. And the other day I was sitting in a program with Dr. Reddy, Srinath Reddy, and he said now the statistics has gone to 20 times. So why aren't we realizing that we are wasting more money and time on tobacco related cancer treatment and tobacco related diseases?
I think this part has to go to the government and to the lobby, those who are promoting tobacco production and cigarette production and users of cigarette, because they don't realize when we were fighting about that there should be a pectoral warning on pack to 75 to 85%, there were so many court cases where we have to fight to get it increased to the 85%. Everybody is saying that we are lobbying for NGOs who are involved in prevention technology, and while they say that the cancer has got no relation with tobacco, they are coming out with all sorts of advertisements and all those. So this thing we have to convince everybody that 700 million rupees if you are earning from tobacco and you are spending more than 2000 million on treatment, then that means that 700 million can be given by government to those people to prevent the farming of tobacco, the production of cigarettes and all those things, so that still we save $1,300 million rupees for the treatment.
Sir, I tell you something here, because we are addressing the general practitioner. The fight is going on at that level, even the lawyers are involved. But I think the role of general practitioner is of immense importance, and I would request the general practitioners at this stage that at least in their OPDs, they should have posters and pamphlets available to create an awareness about the tobacco related diseases. Not only cancer, other tobacco related diseases. And I think Indian Medical Association has to do a lot of work in this, so as to what kind of posters can be created, designed, and they can be sent by the local and the regional branches, so that they, from their budget, they can print and give it to the practitioners of these cities.
Most important thing will be, Dr. Sharma, the initial statement of yours that the tobacco and smoking is the cause of all these cancers. We must come out with the real list of all the cancers and how they are rated and how much percentage is because of all these things, because that will be convincing the general practitioner and to the public also.
You see,
so
we have that. Actually, Indian Council of Medical Research has done a wonderful job. The National Cancer Registry Project, and earlier there were only 5 or 6 cities. Now slowly the cities are getting connected, the hospitals are getting connected. But more than that, I think the general practitioner group or population and the Indian Medical Association should also try to convince our government and the policy makers to declare cancer as a notifiable disease. I tell you, it's a great thing. I had been struggling for this for last 10 years, and at one particular level, the Director General Health Services was very kind, and he accepted that yes, I am proceeding with it. I had given him guidelines how to go about doing things. But what happened, somebody got a whisper, and tuberculosis got declared and the cancer is not. Still, if we convince the government to declare cancer as a notifiable disease, there will be a lot of advantage. The saving of the financial and the financial crunch for health services which you are talking, that can be saved a lot, because once you declare cancer as a notifiable disease, the work starts at Anganwadi worker or a primary health center or at the level of a practitioner who learns how to recognize tobacco related cancers. He immediately reports. Now see the fun, once he reports, like in dengue, the cause or the origin is reported, the action is taken to prevent dengue. So once, I think ICMR work is very good, but this is a stronger evidence by declaring cancer as a notifiable disease to convince the government that look, all the unreported cases of cancer whatever cause, tobacco, poor hygiene, poor nutrition,
So many
trauma, so many things, pediatric cancers, geriatric cancers, age-related cancers, cancers in hereditary cancers, all will get streamlined, and you will find tobacco-related cancers will dominate. And then once the tobacco is confirmed more robustly as the cause of cancer, then I hope that government will at least accept this and try to do something about the total elimination of tobacco, or to do alternative jobs for what they say 40 lakh workers of tobacco. They are worried about the 40 lakh workers of tobacco, but they are not worried about the 40 lakh plus deaths happening.
That's what I'm saying.
Such
that
tragic
two lobbies,
stories. The daughters have gone into prostitute, the sons have become thieves and robbers and extortionists. The wife has been thrown out of the house, and so on and so forth. Come to my OPD, I can show you any type of stories what tobacco has caused to the family. You see, it is a cascading effect. One tobacco related death has got a terrible cascading effect. So this is all about the tobacco. Now coming to the other causes of cancers in our country, we come to the other lifestyle changes. Like the recent statistics you must have heard, people are very fond of telling that the breast cancer is rising. Actually, it is rising in the metropolitan towns, and there is some evidence that it is also rising in the rural areas. Gynecological cancers, yeah, that means the cervical cancers still remains the highest female cancer, and we are the world capital of cervical cancer, unfortunately. Moreover, then ovarian cancers are also raising up head, and sometimes in my OPD in LNJP hospital, I used to get more ovarian than the cervical cancers. Cervical cancer incidence is going down with education and some amount of awareness, but the backward areas of the country and the illiterate population, poorly nourished population, we are still having problems. So now when we come to lifestyle changes...
Dr. Sharma, here I'd like to say, you said the cervical cancers are not increasing, but they're showing some downward trend. Can we relate this with vaccination which is being given to the young girls? Has it got any
No, sir. Vaccination hasn't come to the way it has gone to the Western countries, and actually there also there's a big controversy going on. I have been attending for last 10 years, I have been attending European Society of Gynecology and International Gynecancer Society conferences in various parts of the world, and there is a very heavy debate going on. You see, the point is the HPV virus, which is considered to be the cause. You see, when I was a student 40 years back, we were not talking much of HPV virus. We were telling HPV virus and herpes virus hominis, which assist HPV virus. At that point of time, the cause of cervical cancer was illiteracy, poor genital hygiene of male and female. That is what provoked me to create for the first time the self-examination of private parts for male and female. And if you go to our radiotherapy department, you will find those posters are there about the phimosis, paraphimosis, douching of the vaginal area, and husband-wife understanding about the cancer. Then there was also a cause of sperm head proteins, because early exposure to the vaginal area, so sperm dies and the sperm head proteins. Then smegma was the cause. We used to do an experiment taking smegma from the volunteers, painting on the rat skin and creating cancer. But later on the HPV came in a very big way, and I must say that there is a little bit of a commercial aspect attached to it. Now the problem with HPV is that there are several strains. The first conference I attended was strain 17 and 18 or something. Then 2 more strains were added. Then the next conference I found they are also talking about the skin cancers. Then they also started talking. The Australian came out with a very interesting information that when they started vaccinating boys and girls together, then they found the penile wart incidence dropped down in Australia. So, you know, there was another. Then recent conference I attended was in Melbourne, and they said the nonavalent vaccine, we were talking about quadrivalent vaccine in India. Now they are coming out with nonavalent vaccine because there are 9 strains now available. And the problem with these HPV viruses is that they don't speak to each other. See, you vaccinate one virus strain, it doesn't affect the other virus strain. Moreover, the vaccination, we don't have a hardcore statistic data in our country. We don't have cheap vaccine available. Unless and until there is a population-based vaccination available in a very cheap way, we are not in a position to say it with certainty. The cause of going down of cervical cancer is, you see, I'll cite you the example of China, where the cervical cancer incidence was very high, and then they had one child norm. It just dropped with the incidence.
So that means
The number of children has got a great role. So, you know, I often jokingly say thanks to Sanjay Gandhi, because the population, yes, and the population, people have started realizing two-child norm. So that is there.
That means there are two very important things which are coming out of this discussion. That vaccination has got probably questionable value in prevention of cervical cancer, but definitely the reaction of a sperm with the cervical surface has got a more relevance.
Sir, sperm and myriad of other problems. You see, that's what I'm coming to, the lifestyle changes. You see what the hell is happening to the youth of this country. The sex is free, boys or girls. I have been involved with male sex habit analysis, and the outcomes were horrifying. I had been going frequently for inspection, so I had an opportunity to interview the taxi drivers, and they told me horrifying stories about the ongoings. Now what happens when I started interviewing these youth, hardly 20 to 30% youth said that they love to use condom. They don't want to use. So that means the exposure is direct,
Yes.
number one. It's not the HPV alone. It is an early exposure to the sexual habits, which will include introduction of HPV, probably introduction of HIV, if the boy or girl has got a habit of, and then smegma, and the sperm head protein. So this is all complex thing which is happening. I'll cite you one example. In UK, after the Second World War, there was a great awareness about the genital hygiene and this and that, and the incidence of cancer cervix started falling down. But then in mid-60s, there was a women's emancipation and freedom of sex, and the free sex habits started from school age. I was hearing to a BBC program where they said that 80% of standard 8th children have had the sex experience. And that's happening in our schools also, to tell you the truth. You talk about village and all. So, you know, that point is very serious. Our children are not realizing about the safe sex. We have to teach them about the safe sex, otherwise the cervical...
I'll interrupt you. I should not say that our children are not aware about this. But what about the medical profession? Are we talking about this thing that this is one of the cause of an increasing number of cervical cancers? We are not talking about all these things. We are not telling anyone that whenever you are having sex, please make sure that you use condom, because this is going to prevent not only pregnancy, the most important thing that it is going to prevent HIV, it is going to prevent future cervical cancer, it's going to prevent all kinds of sexually transmitted diseases. This is the importance of a general practitioner to talk about all these things to the families and to the community at large.
Sir, I'll take your point here because this quite gets related to the undergraduate and postgraduate teaching also. Our trainee doctors are not taught about how to approach towards the sexual history and sexual performance evaluation, whether it's a male medical student or a female medical student. I often used to come across giggles and smiles at the back of my students' mouth when I used to talk about the sexual habits of the patients and patients' relatives. they used to say, why are you asking about the exposure and all? Patient may get offended. Then this law came that you cannot get the HIV test done.
HIV testing.
But believe me or not, many of these patients who came with the cancer, we had to get the HIV test done, and many of them were positive. So the whole scenario changed because HIV related cancers are non-responsive. Whether under the ART or not in ART, they will respond, they will become normalized and bounce back with vengeance. And we have lost so many patients.
This is a very important statement made by you, that the HIV patients will have a cancer which is going to be very difficult to be treated by a simple therapy, and even the HIV is going to be very difficult to be treated.
Sir, through this program, I want to tell all my practitioner brethren, very important thing that we have to do. You should see the crowd at the LNJP. You come and see our cancer and HIV clinic floor is the same. There are more HIV patients coming for ART than the cancer patients coming for the treatment. What the hell is happening to the youth and the people? It's so pathetic. So, this is futuristic about the changing patterns of cancer because of the lifestyle changes. Third thing is about the food, I would like to say, and about the obesity and the body mass. You see, one of the main causes attributed for the breast cancer, we said that the breast cancer is very common in metropolitan towns because of the affluence, because of the very rich food, the fast foods, the shortcuts to kitchen, going and eating out, fabulous food, weight gain. The weight gain is considered as a sign of health.
Prosperity.
What happens? The fat deposits the estrogen, and that's the estrogen sitting there also. So we have to talk about the diet and the food and the weight maintenance and the exercise for all the women and men also. Here it is a breast issue, there it's a prostate issue. Very funny. So about this overweight and the dietary factors are very important. Second thing, I had been campaigning for, I had been telling हरी लाल पीली सब्जी और फलों का सेवन देता है कैंसर रहित जीवन. And one day in one TV program somebody joked and he said, sir, भाव इतने बढ़ गए कौन खरीद के लाएगा. But then there is always an opportunity to find cheaper vegetables and fruits when the season comes. There is always an opportunity.
Sure.
Let us remember our Lal Bahadur Shastri at the time of China War. He said, एक फुट जमीन लियो तो उसमें कुछ लगाइए. So I introduced a concept of anti-cancer agroforestry. I said, पेड़ वही लगाओ जो फल दे. If you want greenery, you can have fruit-bearing plants. And then I also said that फल किसी और के पेट में जाए, पर गीता का संदेश पढ़ने वाले को इसकी चिंता क्यों सताए? कर्मण्येवाधिकारस्ते मा फलेषु कदाचन. Let anybody eat, but it will go to someone at least. And then I classified and said metropolitan agroforestry, residential agroforestry. So we should also focus on production of cheap fruits and vegetables. If you see the Facebook, there are a lot of groups, terrace garden ideas, and people are growing vegetables on their terrace garden. So we have to promote, this is going to help, and this kind of education and awareness has to come through the practitioner to tell you the truth when he talks about the diet.
So Dr. Sharma, you have given two very important things, and you're talking about the each and every color of fruits and vegetables should be consumed by everyone in a day-to-day life. And the most important thing is how to avoid obesity, because the obesity is related with all hormones related cancer. So everyone should be taught about how to prevent obesity and why they should take all colored fruits and vegetables, because this is very well established phenomena that the all colored fruits and vegetables give you antioxidants, and each and every antioxidant is definitely going to help the body to regain the lost energy and the fighting capabilities. So everyone should remember that there are two important things. Lose weight, obesity is one of the biggest killer for all sorts of metabolic disorder as well as for the cancers related to the hormones, and eat healthy vegetables and all colored fruits and vegetables, and try to develop, as Dr. Sharma has said, try to encourage small gardens in your home. Whether you have land or you don't have land, you can grow fruits and plants even in your terrace garden, even in your small place of 1 foot by 2 foot or whatever area you have. But that should be a habit of each and everyone, and one should be taught about it. Okay.
See, that's very interesting you said about it. Actually, our practitioner brethren should tell the patients and the patients' relatives, just ask them, "Kitwa ghar mein kya ho raha, what are you growing in your house?" That is, and the funny thing, all of us know, but we don't want to speak about it. Look at the industry which is connected with obesity. Right from the foods to the gyms are running because of obese people.
Because of the best.
And the surgeons who are doing bariatric surgery. And see, tomorrow they will say, don't reduce weight, otherwise this industry will collapse, like the tobacco industry will collapse if you ban tobacco. This is the irony of our times, and I think we, the doctors who happen to be educated differently and brought up differently, we have to take a very serious role, especially at the practitioner level, to change the scenario in the society. So we have talked about this lifestyle changes and all. Now I basically want to discuss a very important thing, what the practitioner faces or what practitioners patients face. I come across with the patients, and many of us who are sitting in the oncological clinics, they come across the patients that we write certain injections for the midnight crisis, and the patient comes and say, "Hamare family doctor ne, he has not given it to me. They said I will not give you this injection. Only your doctor will die." At midnight, far away from the hospital. So our practitioners. And then there are other complaints, like the doctor says that you will have to go to Tata Memorial. The doctor says that this is a cancer, but he has not conducted any tests. What all the tests have to be done? And the doctor says that I will do the surgery, don't you worry, I will remove the gut or tumor, and you will be free of the tumor. There are lots of questions faced. Now I want to tell my practitioner brethren, very important thing. Number one, first of all, we must revive this family physician culture. That's very important. You are actually the backbone of comprehensive oncological management. You are the caretaker, you are the oncopsychiatrist, you are the social worker, you are the nutritionist, you are the, even at times, emergency medicine caretaker for the cancer patients receiving treatment. So therefore, I would most humbly suggest you that if you happen to come across a patient where you suspect the cancer, leave aside two sides, mediastinum, lungs, and peritoneal cavity or brain. You must try to confirm the diagnosis by biopsy. Then there are associated hematological tests which you should do, and radiological simple tests you can do. And then the best thing would be that you refer not to an oncologist but to an oncological treatment center. The second point I want to tell you is that the oncological management, the cancer management, is a comprehensive multi-specialty oncological treatment management. It's not a single specialty treatment. The single specialty management has done more of harm. I don't want to name the specialty about which the journals have started publishing the articles that this particular specialty is responsible for the treatment failure, and many of those specialists must be knowing about it. So it's a comprehensive, and we follow a tumor board culture.
Right.
Now a tumor board is actually, I have been inspecting for the National Board and for the Medical Council of India, and unfortunately this tumor board ethics does not exist in most of our institutions. But you should know about what is tumor board ethics, and you should be asking your patient that how many doctors did a group of doctors discuss your case or not. That's very important. And if that's not happening, you should find out a place where you can refer the case if you want the patient to live longer.
I'll just interrupt Manoj Sharma, because what I like to tell my general practitioners friend, because I still feel the Indian healthcare requires only general practitioners for taking care of 80% of population who is living in the villages, and so the general practitioners should understand what are the basic things in when we are talking about tumor board and multi-speciality way of treating a patient of a cancer. Because now you should understand that the cancer patient is not one patient and not a one disease which is to be treated by a surgeon or with the medical oncologist, by the radiation oncologist, or by the pathologist or by the hematologist. Basically, these 5 doctors form a kind of a group which is called as a tumor board. So each and everybody gives their opinion and take a combined and joint decision for the treatment of a cancer. And especially when you talk about the cancer, now the things are really different every time the surgery is not done. Maybe a chemotherapy is done and then surgery is done and then the chemotherapy and radiotherapy is done. So we must understand the basic phenomena of treatment of a cancer, and this involves all the 3 things. And obviously next will be coming at the genetic changes and all those things, and those are the difficult things. But the common thing, oncology, medical oncology, radiotherapy and surgical, these 3 people should be at least seeing the patient and deciding the mode of treatment.
Sir, taking a cue from you, I just want to remind our practitioner friends, very important. You must have seen the sudden spurt in the medico-legal cases. And I was in MD Anderson, and I was told that each and every file is taken to a lawyer there to discuss. And one clinical assistant who studies MBBS but doesn't practice a patient, she said every doctor pays $75,000 for the insurance. Now medical legal cases are increasing tremendously, and as we were discussing about the tumor board ethics and tumor board approach, a lot of treatments are based on guidelines, NCCN guidelines. Every country has got its National Cancer Institute guidelines. Japanese guidelines are different, Scandinavian guidelines are different. I will come to that why we don't have a guideline and we are copycatting or monkeying their guidelines, which are not quite successful in our country. People don't want to speak about it. This is number 1. Number 2, the combined consensus treatment is also based on guidelines, and actually the guidelines are based on evidence. What you must have heard a name very commonly, fashionably used is evidence-based medicine. What is the evidence-based medicine? Once I talk about evidence-based medicine, I bring you to a very important and responsible job that you only can do, and the foundation of this technology or methodology was laid very much in this country, and UICC and WHO has taken that methodology from Center of Excellence, Adyar, Chennai. Now what happens, the evidence comes from the follow-up. Once what you treat, you should know what has happened. You have treated, I have given you an example that the patient tells the doctor, says guilty निकाल देंगे तुम ठीक हो जाओगे. No, and patient goes home, and then the patient comes with multiple metastasis in the the follow-up is very important, and you are going to play a very important role in follow-up. You as well as the institutions are also required to follow that methodology. What happens at Adyar, that when the patient, first of all, they have got a very good referral system. They are created, the practitioners, they are quite different. They refer the case with a covering letter and whatever investigations they have done to a cancer treatment center, number 1. Number 2, when the case comes, the cancer treatment centers writes a letter to the practitioner. See, giving respect and importance to the practitioner, that thank you very much, we have received the case, it's on the card, and this we call it postcarding. Thank you very much for receiving this case, sending this case, and we are doing this, and we will get back to you from time to time with regards to the progress of the treatment or when the patient gets discharged. Now the patient gets treated, and after the discharge, again a postcard is given to the practitioner. We have done this, we have prescribed this medicine, these are the medicines which you can administer, and these are the medicines that to be administered in the oncological supervision, so you can send the patient, and then the instruction is given to the practitioner, please see to it that the patient comes to the follow-up. Now they have got a software which tells them that the patient who is due for third monthly or sixth monthly, third month, first or second monthly after treatment, third monthly for 1 year, 3 years, sixth monthly for next 5 years, 2 years, and then yearly after 5 years. So they come to know about that software.
Right. Here I am going to interrupt you again, because otherwise I will forget what I want to tell to my general practitioner and to all the specialists and all those people who are getting referrals from general practitioner. What Dr. Sharma has just mentioned, that you send a letter of thanks that we have received your patient and we are doing some kind of a study and treatment, and this is my protocol. And once the treatment has been done, they send a letter that this kind of a treatment was given and this is the result and this is how you are going to follow. If each and every one of us, especially the specialists and the hospital, start doing this kind of service to our general practitioner, their interest in the treatment of a patient will be much more, and they will feel satisfied, and that is the way you can improve the image of a general practitioner in the families, in the community and in the nation. And if we want to do something special for the community and for the nation, and that's the most important thing, that we have to improve the contact with our own general practitioner, we have to improve their image, we have to improve their involvement in a patient, and they should be kept in loop for each and every treatment, not only the cancer, but this, what the cancer hospital in Chennai has been doing, it should be followed by each and every hospital for each and every patient, irrespective of what treatment has been given.
That's right, Dr. Kannan, because patient-doctor relationship improves there, RCP, and then a patient cannot go to the specialist or the super specialist for every small thing. For example, what to eat, what not to eat, there is a vomiting in the patient, patient is having headache. All these issues, I think the GP should be capable of doing, taking care of once the super specialist hospital is guiding him, giving him instructions.
Sir, to tell you the truth, it's happening. I tell you something. But then there is a great role of the treating cancer treatment hospital also. At this center of excellence, and the moment patient comes, they give him a sheet. 6 columns in the front, 6 columns at the back. And he has to write down the address of the patient, patient's first relative, second relative, patient's place of working, patient's friend, Gram Pradhan, your Thana, police Thana, and post office. I had seen general practitioner virtually dragging the patient by the hand. ये मानी ये पो माटे तू क्यों नहीं जाती है चल अभी चल. Doctor, they will say from Andhra Pradesh, from Tamil Nadu, they will bring the patient that you have been sending the cards and she was not responding. Your card came to me, I have brought the patient. That's the status of a practitioner there in Tamil Nadu. And it's not possible because of the practitioner is also very busy. Moreover, the practitioner-patient liaison is such a wonderful thing happening with this, that first thing, if the patient doesn't go, the practitioner provokes. Second thing, rightly he said about the complication, midnight crisis. Here I think our oncological centers have lagged behind. They have got material available in English but not in vernacular. Some places it is. I had done a book called Cancer Chikitsa, इसे सहर्ष कैसे पूरा करें, that is cancer treatment, how can you go happily through it. Second one is I am doing on oncopsychiatry in Hindi. You see, the hospital's responsibility is also there to give them a brochure or a booklet to handle to the midnight crisis. which he should be able to show to the practitioner. In all the cases, if a common man cannot understand what is written in the book, the practitioner will understand it better and attend to the patient's midnight crisis or the problems. So, therefore, the practitioner is, I told you that patients say that the doctor is not giving me the injection, saying that. Now, here comes a very important role, that the practitioner should also spare some time and find some time to attend the hundreds and thousands of seminars and clubs and meetings and conferences that are happening related to the cancer specialties, to attend them. They can just find out what is their inclination, what is their interest in which type of cancer, and if they start coming, and it is happening, they are coming to these conferences as practitioners. They are proud to say that I am a general practitioner, but I want to know more about. So, they will get an idea, because a practitioner is, I should not be using the term jack of all trades. Actually, he is jack of all trades. And he is not seeing cancer alone, he is seeing everything. Even the patient's personal family problems also he is attending to. So, therefore, I will stress for cancer, because cancer is happening a major killer, it's going to be a major killer. And cancer is one disease that if you are a family doctor, you detect the disease in an early period, you say you become the God and the savior of the patient. हाँ, उन्होंने मुझे भेजा था अस्पताल, देखो टाइमली ट्रीटमेंट हो गया, हमारे डॉक्टर साहब नहीं होते तो मैं तो अस्पताल जाती नहीं, something like this. I am speaking Hindi. अच्छा, therefore, the practitioner's role. Now, another question the patient's relative asks, that can my doctor do an early detection of cancer or survey on me? And it's very simple. The practitioner, if a patient comes or the practitioner suspects that there is a family cancer in the family, or there are symptoms that are related to cancer in a regular patient who is coming, or the child or the adult or the elderly, whosoever, then he should advise certain investigation. For females, I have been recommending simple investigations. Cost of everything has gone up. A simple blood, a clinical or a gynecological examination, where you do gynecological internal examination, abdominal examination, nodal examination, and also an X-ray chest, in ultrasound, because ovarian is really becoming difficult. All the cases come in stage 3C, where the survival is not more than 35 to 40 months. If patient is married or already consumed to the marriage, then they transvaginal ultrasound. And of course, in case there is a suspected breast lump, so above 35 years, a mammography, and below 35 years, an ultrasound. These are the simple tests, but out of all these, the clinical examination, a parvaginum, colposcopy or whatever is very important. Similarly, for male adults, especially the tobacco users, the clinical examination, a low intensity care, the sophisticated X-ray of the chest if he has got a symptom, a clinical ENT examination, simple oral examination and posterior indirect laryngoscopy, abdominal examination. In case the symptoms are related to urination or defecation, a rectal examination, and these simple tests can be carried on. If the facility is not there, they can arrange it in a government hospital. People don't go, people don't send. Practitioner role is to convince the patient that look, this is, I am telling you for good, don't be afraid of running from pillar to post, hospital ke dhakke khane se tum ghabrao mat. You go and get these tests and you will be surprised that there is a great thing happening in these cases, and they are, in this continuation I want to tell you two more things, because I think we are running short of time. One thing is, I would request all my practitioner friends that if they make a small little group and take a school by school to conduct at least one health checkup annually. And once they do it, there will be a great lot of problem which will be solved in terms of curing all kinds of diseases and early detection of cancer. And in that
Question? What's that?
okay.
Whipping checker. Okay. Good day. Great initiative. Everybody is saying great initiative, good work being done by you. Sir, what are the risk factors for this disease? He has not mentioned, Gauri Shankar Maurya has not mentioned about the disease, but he is writing. What are the risk factors?
Risk factors we have been already discussing about.
You did not
and
touch upon genetics part of
yes,
it.
I'm also talking about the. I would.
More important, I think this is going to be important is what lifestyle changes such as diet, exercise and rest should I make to be healthy before, during and after treatment. Someone is asking that before, during and after treatment, how to keep myself healthy, because most of the time the cancer patients face a problem of losing weight, not able to eat, so those things. For that they want.
I wonder, I am loading you with lot of responsibilities. I have already noted down to discuss with you. First of all, I'll start from school, health checkup, and then I'll come to the self-examination. You see, the patients who are coming to your clinic, you may not be a cancer specialist, but you know, to create a general awareness to detect the cancer in an early stage, self-examination of breast, self-oral examination in tobacco users or with people with a bad orodental hygiene, self-examination of private parts for the males and the females, because you know, in males, the above the penis, the skin, what you must be knowing, there's a situation called phimosis or undescended testes. These are very important things. So the self-examination of private part explains it very well. If necessary, I can put that thing in IMA magazine. Then self-nodal examination, especially where people have a frequent occurring of patient having tuberculosis node or other node or a fever. That's very important. These are some of the self-examinations which can be slowly introduced to the public like this. Coming to the risk factors, the risk factors are basically, I will consider the risk factors could be your environmental pollution. Risk factors could be the wrong type of diet. Risk factor could be certain infections like Helicobacter pylori, like hepatitis. People don't get vaccinated for hepatitis. Hepatitis vaccination, HPV vaccination if it is cheaply available. So there are certain types of infections which are also considered to be risk factors. Then comes one very important risk factor which is being debated, and the confusion and the competition is with that of a tobacco. When the tobacco came, every film star used to smoke. Like every young man uses the mobile phone, and we are having a very serious discussion of mobile phone carcinogenesis, because WHO has already graded it as a potentially dangerous, I think 2B category, and the ministry has already formed a committee. But we are facing the same problem like tobacco industry, the mobile industry. And if you see the technology of mobile transmission in developed countries and our countries, that we will discuss later on. Now
we are running short of time also.
About the diet and
we need
treatment.
to continue this topic for
another time. We can
Yes, but
continue.
I will conclude this topic because I said I am loading you with so much of responsibility. I have already mentioned, noted. You see, when the patient is under treatment, first of all, you should know what are the kinds of complications related to the post-surgery, post-radiation, chemoradiation, and immunotherapy, number one. So that you can always read in the website. You have to take weight of the patient and get his hemoglobin checked if there is a gradual fall in weight. So you are also playing the role of nutritionist. The right kind of diet you have to, and if the patient is not responding to diet, you have to report to his doctor concerned. Post therapy is important because of the rehabilitation, and as I repeatedly say, the follow-up, the immediate complication and late complications like intestinal obstruction may set in, the perineural fibrosis may set in, the vaginal stenosis may happen, the urethral stenosis may happen. So this should be under your observation, and if the patient requires physiotherapy for a treated area, he should go for, say for example in breast, the edema comes, the hand movement, the physiotherapy has got its role. So you know, these are the kinds of things you have to note. And I think we still have to continue, because responsibility, remember, the responsibility of yours is simply tremendous, and you have to realize, and oncological community has also got to realize how they lay their trust on you, how they interact with you more. Lastly, I will say, the moment you come across a cancer patient or you diagnose a cancer patient, please take the address of the hospital, and please take the telephone number of the doctor, cancer specialist who is treating that patient, so that you become the savior in the time of crisis. You can directly contact the doctor and ask, your patient is being looked after by me, so please tell me this is the thing, please advise me what to do.
So, Dr. Sharma, as you mentioned that we doctors should go to schools and teachers out there. We have started our school chalet program, which we are conducting all over India, one day all over India, and we are going to teach students regarding all the problems which are happening, how to prevent and how to diagnose and how to take care of each and everything. So we are trying to do all those things. I'll request Dr. Monga to say.
With this, I think we need to conclude this, because it's already 4. But the major issue is that Dr. Sharma, you told the basics to a GP, how to talk to a patient, how to send a patient, when to greet the patient back, how to do it, understand his problems also. I think these type of issues should go well with the general practitioners, and we should be definitely more intelligent on this front. With a person like Dr. Sharma telling us all these things, I think we are lucky to have you today, sir, in our show. And we promise that we will continue this, because we have covered only half the topic. At least half is left. The follow-up, the choice of radiotherapy or chemotherapy or medication, all these things will go into these in one of our next programs. Till then, we'll see you again next Thursday.
I'd like to thank Dr. Sharma for coming to IMA for this webcast, and all those people who have taken so keen interest in sending their questions. So we could not take up many questions, but most of the questions have already been answered during the discussion with Dr. Sharma. So thank you everyone for the watching IMA webcast, a weekly webcast, and see you again next week, same time, same place. Thank you and bye-bye.